Does it look okay?
Yes.
Okay, great. So let's start. So today we're going to talk about leg ulcers and coagulopathies. And as we introduce myself, this is today's panel. Then we have two sessions today, and I'm going to talk about the background and basic knowledge about the leg ulcer and coagulopathies. And then Dr. Ruotsi will talk about clinical features and case studies. So, chronic leg ulcer is a defect in the skin below the level of the knee, and it presents for more than 6 weeks and show no tendency to heal after 3 or more months. According to the Wound Healing Society, approximately 15% of all adults in the United States suffer from chronic wounds, which is a great number. Then when we talk about chronic wounds, usually they predominantly include venous stasis ulcers, pressure ulcers, and diabetic foot ulcers. And one of the major risk factors for the leg ulcers is hypercoagulable states. This is an increased tendency to develop blood clots due to some factors, which can be inherited or acquired conditions predisposing an individual to venous or arterial thrombosis. And it increases the risk of developing thromboembolism, such as deep venous thrombosis, pulmonary embolism, and a Birchall's triad. And this condition can present with a wide variety of cutaneous wounds, such as venous ulcers. And cutaneous findings in hypercoagulable states are not specific to a certain condition. And the condition can be separated into primary and secondary hypercoagulable states, which I'm going to talk about later. And the recognition of signs of hypercoagulable states will prompt proper workup. So there are many risk factors or causes for venous and arterial thrombosis or like hypercoagulable states. For the primary hypercoagulable states, they are mostly related to inherited conditions, kind of like genetic mutations, such as factor V Leiden, prothrombin mutation, or like antithrombin protein C, protein S deficiencies. On the other hand, the secondary one, for some situations requiring rest or causing immobility are the risk factors, such as like hospitalization or surgery, and some physical status like pregnancy or obesity, and some specific diseases are also risk factors like antiphospholipid antibody syndrome and cancer, and kind of like that. And also some medications are also risk factors, and I'm going to introduce the details later. And to understand what occurs when you have hypercoagulable states, here we want to review the normal coagulation and healing process when you get injured. So the healing response usually begins immediately after you get injury, with the process of hemostasis initiated by the contact of infiltrated platelets with exposed collagen. And in the normal condition, breathing stops immediately because of many platelet factors. But one example of the deficiencies is von Willebrand factor deficiency, in which platelets doesn't stick together as they should. So it takes a long time to stop the bleeding. On the other hand, we want to focus on other types of deficiencies that generate excessive blood clots as a risk factors for leg ulcers. And these images are just now images of activated platelets and fibrin clots when you get injured. And among the blood coagulation factor deficiencies, the protein C deficiency is one of the common risk factors for hypercoagulable states. Protein C is an inactivate enzyme playing an important role in regulating anticoagulation, which means protein C inhibits coagulation. So protein C deficiency is a rare genetic feature that increases the risk of developing abnormal blood clots in your body, resulting in venous thrombosis. And another condition related to protein C is activated protein C resistance, which is inability of protein C to cleave factor V or other coagulation factors. And next one is protein S deficiency, which is kind of similar to protein S deficiency, because protein S is another anticoagulation factor, which is partly homologous to protein C. So it also has a role in the anticoagulation pathway, and its deficiency increases the risk of developing abnormal clots. And protein C and S deficiencies are autosomal dominant conditions affecting 2% and less than 0.1% of the population. And the deficiencies lead to unbalanced activation of clotting factors and increased production of thrombin. And they have a potential role in warfarin necrosis, despite the anticoagulating effect of warfarin, because initially when you take the warfarin as a medication, the warfarin inhibits protein C more strongly than the other coagulation factors, so resulting in massive thrombosis. And the next one I'd like to introduce is antiphospholipid antibody syndrome. This is an autoimmune disorder, which means like your immune system mistakenly creates antibodies that attack tissues in your body. And these antibodies can cause blood clots to form in arteries and veins. And its signs and symptoms vary, but may include blood clots, miscarriage, rash, chronic headaches, dementia, and seizures, etc. And these images are examples of ulcers caused by antiphospholipid antibody syndrome. And acquired antibodies against cell membrane phospholipids are produced in this disease. And the diagnosis for this condition is made based on the presence of the antibodies and a thrombotic event. And skin or wound findings related to this condition include venous ulceration and the superficial thrombophlebitis. The next risk factor for the hypercoagulable states is factor V Leiden. This is also a genetic mutation that can increase your chance to develop abnormal blood clots. And this is the most common risk factor for the primary hypercoagulable states, 5 to 15% of the population is affected. And about 20% of patients with initial venous thromboembolism have factor V Leiden mutation. And this is the prothrombin mutation, which is the second most common reason for the hypercoagulable states. like about 5% of population is affected. And this is also an autosomal dominant pattern and present in about 10% of the initial venous thromboembolism. And this mutation in the prothrombin gene leads to elevated plasma level of prothrombin and increased thrombin formation due to excessively produced factor 2. This is one of the most difficult to pronounce, but this condition is methyl and tetrahydrofolate reductase mutation, in which resulting in hyperhomocysteinemia. So this mutation leads to elevated levels of homocysteine, which is a risk factor for arterial and venous thrombosis. And these are actually like inherited condition and acquired condition related to hyperhomocysteinemia. And the acquired homocysteinemia can arise from renal disease, smoking, aging, and deficiencies in some vitamins like vitamin B12, B6, and B9, which is folate. And I think this is the last genetic mutation is for the primary hypercoagulable states, which is antithrombin 3 deficiency. This is the first genetic deficiency that defines a thrombophilic state. And this is also an autosomal dominant pattern and occurs in less than 0.02% of the population. And this condition leads to an increase in activated coagulation factors. And also there are both inherited and acquired conditions of this antithrombin 3 deficiency. And the acquired form of this deficiency can result from like infection, sepsis, DIC, or like hepatic failure. And next, here I'm going to introduce some knowledge about secondary hypercoagulable states. So like I said before, one of the major risk factors is hospitalization, because immobility is the biggest risk factor. Also, major trauma is an exceptionally high risk, where at least one deep vein thrombosis in 58% of traumatic patients. And also, obesity is another risk factor. Actually, the exact mechanisms of the relationship between obesity and hypercoagulable states is still understudied, still unclear. But some studies showed BMI was correlated with venous thromboembolism. And also it was shown that central obesity and elevated leptin and resistin levels, which are hormones regulating weight and glucose metabolism, may be associated with thrombosis. And as you may know, cancer is also a major risk factor for secondary hypercoagulable states. Like venous and arterial thrombosis occurs in 15 to 12% of cancer patients. And venous thromboembolism is the second leading cause of mortality in cancer patients. And in cancer patients, you can see elevated levels of some coagulation factors, including factor 5, 8, 9, 10, or kind of like that. In addition, some specific medications are also a risk factor, including sex hormone-related medications such as estrogen or oral contraceptives. And also, some chemotherapy agents are also risk factors. And notably, potential paradoxical thrombosis with heparin and warfarin are observed. In addition, pregnancy and postpartum periods are also risk periods. like venous thromboembolism occurs in 0.5 to like 2.2 cases per 1,000 pregnancies. An increased production of thrombin and increased some coagulation factors are observed in the pregnant women. And finally, I would like to discuss a little bit about whether COVID-19 infection is a potential risk factor for ulceration. So far, there have been no reports showing a statistical increase in ulcerations by COVID-19 infection, other than some case reports. Like there are some case reports showing some like potential relationships between the COVID-19 infection and hypercoagulable or ulceration. But as you may know, COVID-19 disease is often associated with major blood hypercoagulability, as shown by an increase of D-dimer, which is one of the coagulation biomarker. And another study reported COVID patients with cardiac injuries showed increased in other blood test result, like flow thrombin time, activated partial thromboplastin time, and D-dimers. In addition, as discussed in the earlier slides, since the treatments for severe COVID-19 patients may take a long time, they may need a long hospitalization. So such prolonged hospitalization may increase the risk of hypercoagulable states and ulceration. A systematic review and meta-analysis reported the incidence rates of pulmonary embolism and deep vein thrombosis in COVID-19 patients. And they were 16.5 and 14.8% respectively, which is kind of very high number. So we may need to consider histories of COVID-19 diseases as a risk factor for the ulceration. So that's it for my presentation today. Thank you for your listening. And let's move on to the Dr. Ruotsi's talk. Sorry, I quit my.
All right, hello again. Sorry about that. The presentation was on the last slide, so I guess I was trying to give you the pearls before the rest of it. Anyway, I'm going to show you some cases now of actually some of the ulcer-causing conditions that Taichi already spoke with you about. And then a few more run-of-the-mill case studies of venous leg ulcers. I should point out that I was part of the wound scene investigation team, if you will, back in 2018 and subsequent years. So I'd just like to give a quick shout out to the other folks that were on this panel when it was delivered SAWC Spring 2018. So the other panelists were Dot Weir, WOCN, who is also the co-chair of the SAWC meetings, Dr. Bob Diegelman, a retired biochemist from Virginia Commonwealth University in Richmond, Virginia, Dr. Greg Schultz, biochemist and retired professor from the University of Florida, Dr. Lisa Gould, a plastic surgeon and PhD in Rhode Island, and myself. So just want to give some credit to all of those folks for having something to do with many of the slides in here. So statistics, quickly, venous ulcers represent about 60 to 80% of all lower leg ulcerations. Only about 60% on average are healed by 12 weeks. 3/4 of them develop a recurrence within 3 weeks. Treatment expenditure is about $34,000 per case, and about 4.5 million work days per year. This was a study done by Dr. Shandon Sen and published in Advances in Wound Care back in 2019. So venous leg ulcers are a big deal. I would caution, though, that many of the ulcers, if not all of the ulcers that we're discussing today, also occur on the lower extremities. So we really have to have a high sensitivity for thinking about things other than venous leg ulcers on the lower legs. Clinical features of venous leg ulcers: the edema progresses proximally from the feet and the ankles as venous hypertension develops. It tends to be an aching discomfort, worse after prolonged standing or activity, improved if you sit down and elevate your legs. The hyperpigmentation that you see in that lower right-hand picture is due to hemosiderin deposition, hemosiderin being a breakdown product from iron in the hemoglobin molecule. And then we see chronic inflammation, fibrosis, and dermatitis of the lower legs, commonly called venous stasis dermatitis, which is a symptom of the underlying inflammatory process. The ulcers are commonly seen in the gator region, which is the area between the ankle bones or the malleoli and the mid-calf. Used to say to Dr. Schultz, this is not like the Florida Gators at the University of Florida, but this is the gator on your leg. And the erythema secondary to venous dermatitis is commonly mistaken for cellulitis, if you take a look at the picture on the upper right there. So why does chronic venous insufficiency develop? It's the fundamental problem is the failure of the valves in the superficial, deep, and perforator systems. So this valvular incompetence leads to a reversal of flow or insufficiency. That reversal of flow then leads to venous pooling in the lower extremities, resulting in venous hypertension and then varicosities, dilated veins. That persistently high hydrostatic pressure caused by the venous hypertension then distends the thin-walled veins. That increased pressure overcomes the osmotic gradient, and then that inflammatory protease-rich fluid extravasates out into the soft tissues, and we see edema, varicosities, venous dermatitis, and ulcerations as the end result. So venous stasis dermatitis, this patchy, scaling, inflammatory skin change in response to the chronically elevated venous pressures and fluid extravasation. So we see a little bit of hemosiderosis in the top right-hand picture, but that top right-hand picture is just such a classically perfect picture of chronic venous stasis dermatitis. Now, I want to make a special point about the picture on the bottom with that bilaterally symmetric, well-demarcated erythema. This man was admitted to the hospital for cellulitis. So I like to differentiate cellulitis from cellulitism. And so when we see a bilaterally symmetric, well-demarcated erythema of the lower legs in the absence of any clinical or laboratory or vital sign evidence of infection, we need to think about the erythema of venous insufficiency rather than cellulitis. So just coming up the next few slides now, just a potpourri of various presentations of venous leg ulcers. Venous leg ulcers tend to have irregularly shaped borders, but nonetheless well-defined borders. The picture on the far right is a little bit contrary to that, but typically they'll have well-defined borders. That picture you see on the left, that that fibrinous, that yellow fibrinous material in the wound bed. Of course, we want to debride that out of there in order to get to a granular wound bed that we can get closed. The picture on the left, a very common presentation of hemosiderosis with a full thickness venous ulceration right in the middle of it. For some reason that has yet to be explained to me, the apex of hemosiderin staining always seems to point towards the head. I've asked that question of so many vascular people, and so far they've all looked at me like I'm crazy, so I'm not sure what the answer is. Another typical set of venous leg ulcers on the right-hand picture, another one on the left. And so the picture on the right, again, this is a dark-skinned individual, but you can still see that hemosiderosis is so much darker, and he's got a couple of clean venous ulcers in the middle of that area. The picture on the left, we're not going to talk about this today due to time, but lipodermatosclerosis is the progressive development of fibrotic tissue in the lower calf and ankle. So this tissue shrinks up, it becomes very firm and inflexible, and ulcers in these types of tissues are very, very difficult to heal. So this, here we see in this picture, edema, hemosiderosis, lipodermatosclerosis, and a venous leg ulcer over the lateral malleolus. So on to a few case studies. Case study one is a 27-year-old male with a completely unremarkable history until age 19. When he was 19, he developed an occlusive right popliteal vein and femoral vein thrombosis, followed by what he described historically as a storm of clots. He was anticoagulated at that time. A year later, he developed multiple pulmonary emboli, was treated with thrombolysis, which then was complicated by a cerebral hemorrhage and a resultant hemiparetic stroke. Eventually, he went on to occlude his bilateral iliac veins and his inferior vena cava. He underwent venous grafting or bypass of his iliac veins as well as the inferior vena cava, and then developed a postoperative methicillin-resistant staph infection and graft rejection. He had been seen at 3 tertiary centers in the United States, and the diagnosis remains unsubstantiated. Still don't have a firm hypercoagulable diagnosis, other than that we know, of course, that he's hypercoagulable. He's maintained at this point in time on rivaroxaban, clopidogrel, and aspirin. So this was his exam, and this was all of these cases. I think that I'm sharing with you are from our practice here. So you look at this diffuse hemosiderosis, mild edema, small tender ulcer in the medial hindfoot within that area of atrophy blanche. So on the left-hand picture, as well as in the center picture, just above the ulcer, you can see those whitish patches. And this is an area of soft tissue called atrophy blanche, a skin disorder that also leads to difficulty in healing because of impaired oxygen delivery to the skin. His dorsalis pedis and posterior tibial pulses were briskly palpable and biphasic by handheld Doppler. So our plan was hydrogel and foam for the ulcers and multi-layer wraps. We got a venous Doppler with an insufficiency study, continued his present medications, and did refer him for another hematology consultation. He did well, and to the best of our knowledge, following the multi-layer wrapping and continuing on his present meds. These ulcers remain closed to this date, and he wears either 30 to 40 millimeter compression hose or hook and loop or Velcro closure garments on both of his legs. Case study 2, 39-year-old guy with right ankle ulcerations for the past year prior to coming to see us. He had been told at another facility that he should have a below knee amputation. His family history revealed that his mother and brother both had pulmonary as well as cerebral embolic disease. Hematologic workup revealed protein C deficiency, and imaging revealed lateral malleolar osteomyelitis, due presumably to the fact that these ulcers had been in place for so long. We referred him to general surgery for, what happened to those pictures? Oh gosh. I'm missing a couple of pictures and I apologize for that. I don't know what happened to them. But on this slide, there were pictures of these two ulcers of similar size, but with very sloppy yellow and brown and fibrin-filled wound beds. So he had a good operative debridement using Versajet. The osteomyelitic bone was debrided. IV antibiotics were given and guided by bone culture. So another good reminder that the only way to be sure that we're treating the right bugs in osteomyelitis is to have an actual culture of the bone. Negative pressure wound therapy and initiation following the hematology consultation. Actually, we sent the hematologic testing from our initial clinic visit and then got him hematology follow-up. Initiation of chronic anticoagulant therapy was then undertaken. He had subsequently split thickness skin grafts with ongoing negative pressure wound therapy, and his wounds were completely closed at 3 months. So again, you know, a guy walking around the community with these big ulcerations on his leg doesn't know why. And it's an illustration, again, or a reminder, I should say, of the importance of taking a good history, including the family history, because without having taken the family history, we would not have known about his brother and his mother and would not have known to send the coagulation profile. Case study 3. A couple of these pictures are going to look familiar to you from Taichi's presentation. This is a 63-year-old lady with a past history of factor V Leiden, methyl tetrahydrofolate reductase deficiency, rheumatoid arthritis, and hypothyroidism. She came to see us about 1.5 years following an Achilles tendon repair with a post-op wound dehiscence, which had been treated quite appropriately by her plastic surgeon with debridements, flaps, and grafts. She had had multiple topicals and several courses of systemic antibiotics. So in February, we initiated a surfactant cleanser to be applied on a daily basis. And as we followed her over the next several weeks, that wound cleaned up well. If you look at the left-hand picture, your first inclination may be to use enzymatic debridement on that. However, that had already been tried with her. So this was not necrotic tissue, and this responded very nicely to a surfactant cleanser. You see the picture on the far right from March 5th, and she was then referred for split thickness skin grafting with negative pressure wound therapy. That happened on April 12th. Multi-layer compression was continued over the top of the negative pressure wound therapy, and her wound was finally closed on May 20th. Case study 4. This is a fairly straight up venous leg ulcer. However, a reminder that most venous leg ulcers do start with some sort of trauma, and then they're unable to heal due to the venous insufficiency. So this is a 56-year-old male construction worker, history of multiple past venous leg ulcers, and had a traumatic injury to this leg 3 months ago. No other really significant past medical history. His lower extremities were well perfused, good biphasic pulses by Doppler. We dressed his wound with a gelling fiber dressing covered, oh, I'm sorry, that should be a bordered foam dressing rather than a brand name, my apology. And then a 4-layer wrap was applied. On day 2, he came back, and take a look at this, this wound. So these are both from the same day. That top wound was then debrided with ultrasonic debridement on that date to result in the bottom wound. And he was continued on a gelling fiber and a bordered foam and continued 4-layer wrap. And so as we progress through his treatment course, day 6, day 23, day 40, day 46. On day 46, you start to see this neoepithelialization creeping from the bottom aspect of the wound up. Day 60, much more epithelialization. And by day 67, so a little over 2 months from the start of therapy, he was closed. So, you know, a reminder not only of appropriate wound care, but the importance of multi-layer compression whenever possible in the treatment of venous leg ulcers. Case study 5, another venous leg ulcer. This was a 63-year-old male who came in with multiple lower leg ulcers, which had been present for 4 to 5 months. He had been seen in a neighboring wound center where compression therapy was not utilized. Now, this patient initially declined compressive therapy in our clinic, so I don't want to blame the prior facility for not offering compression. He may have very well refused it. However, we discussed multi-layer compression with him as the accepted standard of care. He begrudgingly agreed to as he described it, a short trial. So these were his legs when he first came in. And I know there's a lot of pictures here, but I wanted you to have an idea of what a mess these legs were. So this is day 1. We started him in multi-layer compression. 3 days later, look at the reduction in edema already compared to what you see back in this picture. So reduction in edema, and already in 3 days, a little bit of improvement in his leg ulcerations. And at 10 weeks, he was completely closed, significant volume reduction in his legs. And so, you know, the drainage has to go somewhere. And a lot of it went into the dressings. Much of his lower extremity volume went back into his central circulation and processed appropriately. A couple of thoughts on pharmacotherapy for venous leg ulcers. There hasn't been a great deal published on this topic. However, in the references on the bottom, the top reference you see O'Donnell, Paston, Marston, Ennis et al. Back in 2014, there was a beautifully done consensus document, clinical practice guidelines for the evaluation and management of venous leg ulcers. This was a joint publication by the Society for Vascular Surgery and the American Venous Forum, published in the Journal of Vascular Surgery. And so in that article, they talked about a pentoxifylline, or what we know as the brand name Trentol, as a potential adjunctive treatment in venous leg ulcers, because it is thought to improve red blood cell deformability, reduce blood viscosity, and reduce the potential for platelet aggregation and thrombus formation. Now, another non-pharmacologic therapy, the micronized purified flavonoid fractions. This is an oral phlebitropic drug, which has been shown to improve venous tone as well as lymphatic drainage. Now, I will say that there's been quite a bit more literature out in the last 3 or 4 years regarding purified flavonoid fractions. And now just a couple of oddballs, and then we'll close out. I know that Taichi mentioned warfarin-induced skin necrosis. This is a really unusual phenomenon. However, it occurs in the presence of protein C and or S deficiency within 3 to 5 days of initiation of warfarin therapy. So this is not a condition that you see after somebody's been on warfarin for 2 or 3 years. We know that warfarin inhibits vitamin K dependent clotting factors, including factors 2, 7, 9, and 10, as well as protein C and S. So there's a temporary hypercoagulable state caused by inhibition of proteins C and S. Polycythemia vera. This was not in the original session back in 2018, but I wanted to throw this in for this particular event. Polycythemia vera is not a rare condition, and it is the increased production of red blood cells by the bone marrow. The blood becomes thicker, if you will, and these red blood cells then sludge, leading to thrombosis, occlusion, and ulceration. This is a genetic mutation, happens in men more often than women. Treatment is either phlebotomy, or what used to be called bloodletting, or hydroxyurea. So this is sort of a double-edged sword, because polycythemia vera in and of itself will cause skin ulceration, and then hydroxyurea, which is the treatment for polycythemia vera, is an inhibitor of wound healing. So this is the foot of a man that I took care of with polycythemia vera on hydroxyurea, and just sort of very tedious, gradual enzymatic as well as sharp debridement, and the slight lowering of his hydroxyurea dose by his hematologist. But this is one of those things where I always consult my hematology colleagues. I certainly don't lower the doses of these medications on my own. A lot has been talked about regarding the adverse impacts of anticoagulants on skin and wounds. And really, when it comes down to it, there really isn't a lot there. Aspirin can rarely cause rashes as well as blistering or phototoxic reactions. P2Y12 clopidogrel, or what we know as Plavix, can cause a rash and sometimes an allergic angioedema, swelling of the lips and the tongue. PD3 inhibitors such as cilostazol or Platol, potential toxic epidermal necrolysis has been reported with co-administration of cilostazol with carbamazepine and possibly omeprazole. So again, a pretty convoluted combination there before it causes any skin problems. Dipyridamole, or the old-fashioned persantine, rashes, itching, eczema, one case of Stevens-Johnson syndrome reported. The vitamin K antagonists like warfarin. Warfarin necrosis, but on the whole, extremely rare. Heparins, again, relatively rare. We can see local erythematous plaques at the site of administration of low molecular weight heparin, and that is the most common. Factor 10A inhibitors, the new novel anticoagulants, rivaroxaban, apixaban, rare reactions, and the thrombin inhibitors such as dabigatran, again, rare reactions. So concluding overall, the rate of skin-related adverse events with anticoagulants and antiplatelet drugs is relatively rare. Additionally, there's no evidence to suggest that they actively impede wound healing aside from problems due to hemostasis. So closing out with a few pearls. Always exclude hypercoagulable states with long-standing ulcers on the lower extremities. Remember to take a good history. Work up for autoimmune disorders if your venous leg ulcer is not resolving according to plan. Early mobility, very critical. Patients with venous leg ulcers are often told to go home and elevate their legs. That's a good idea, but in addition, they should exercise their calves and walk as much as possible. Remember the risk-benefit analysis of anticoagulants. Remember that multi-layer compression is the gold standard for the treatment of venous leg ulcers. And last but not least, well, almost last, don't forget skin cancers. Basal cells, squamous cells, and melanomas all occur frequently on the lower legs. So biopsy when you're suspicious, when something doesn't look right, or refer if you're not comfortable biopsying. And last, no smoking. So at this point, I will pass it over to Dr. El-Masry for a wrap up as well as some questions. If I can figure out. There we go. Mohamed, all yours.
Yes, yes. Thanks so much, Dr. Ruotsi, for these interesting clinical cases. Actually, it was wonderful cases and demonstrative presentation. And I would like also to thank Dr. Goto for his detailed and informative background about like the hypercoagulable state. And I would just like to remind the attendees to put their question and answers in the questions in the question and answer box, and we'll try to address as many questions as we can during the remaining 10 minutes. So my first question to Dr. Goto. You indicated in your presentation the relation between the COVID-19 infection and the increased risk for the DVT and pulmonary embolism. Do you think, or you have any information or reported cases about the relation between the vaccination, not the COVID-19 infection itself, the vaccination against the COVID-19 and the embolic incidence?
So thank you for your question. That's a good point, actually, because it's already reported there's some coagulation as an adverse event from the a specific vaccination from I think 2 companies. Yeah, but in my best knowledge, there's no much statistical increase of hypercoagulable states by vaccination from more major vaccination from Pfizer and Moderna. So, but there's still no promising study, I think. So we need to wait the result of more a big sample size.
Okay.
And I think, Mohamed, as you pointed out earlier when we were talking about this, the incidence of those hypercoagulable events with those vaccines from those 2 companies were extraordinarily rare. I mean, I don't remember the percentage of people, but I want to say it was less than 0.1%, right?
Yes, yes, I totally agree with you. They are very rare cases, and actually, with the cost-benefit analysis, it will waive whatever the incidence of the complication which is happening. So we have a lot of other questions related to the clinical cases for the venous leg ulcers, specifically the case number 4, which you presented, Dr. Ruotsi. So they are one question saying those ulcers were little bit deeper. Do you believe that the pure venous leg ulcers commonly present as deep, or will be only superficial?
Interesting. So if gosh, I don't remember exactly which one was case 4. If that was the one with the deep ulcer on the ankle, that was initially a traumatic injury. So that started as a hematoma following his work-related injury. And as most of you are probably aware, hematomas, the defect left by a hematoma can be quite deep. So I should have pointed that out up front, that not only that it was an injury, but that it was a hematoma. And so after we evacuated it, that was what we saw. But nonetheless, his wound healing failure was due to documented venous insufficiency. And I think the answer about venous leg ulcers, are they typically deep or more superficial? Venous leg ulcers tend to be full thickness. In other words, through the epidermis and the dermis. When you debride them, you'll get down to a granular wound bed. However, they do not typically go deeper than the subQ space. In other words, you won't see named structures in a venous leg ulcer.
Okay, great. So then, for the interest of the time, we'll go through the remaining questions like very quick, like each one 30 seconds. So have you any experience ordering an advanced lymphatic pump to patient with recurring venous leg ulcers? Would you also agree to wearing compression after healing?
Yes, so 30 seconds, here we go. There is an indication for pneumatic compression garments for chronic venous insufficiency ulceration after the patient has undergone an appropriate period of time, and it may vary in states, an appropriate period of time of appropriate compressive therapy with multi-layer compression. So yes, there most definitely is a role for pneumatic compression therapy in longstanding and recurrent venous leg ulcers. Also remembering that the vast majority of chronic venous insufficiency ulcerations also have a component of lymphedema.
Great. So we have another question here. Do you think that the data regarding lack of healing in venous leg ulcers is due to lack of standard of care?
Interesting.
This is like coming from like Lisa Gold.
Caroline Fife wrote a really good article some years ago about, and it was entitled, "Why is it so hard to do the right thing in wound care?" And she talked about the fact that so many wound centers don't use multi-layer compression, and so many wound centers don't provide appropriate offloading for diabetic foot ulcers. So I think that it's improving. It's well understood that multi-layer compression is a standard of care. So I think the data is probably better than it was back when Caroline wrote this article. But we continue to see people with longstanding venous leg ulcers who have never been compressed. So I think that's part of the problem. And the other part of the problem is that an untreated venous leg ulcer, there are a lot of matrix metalloproteases creating that prolonged inflammatory state.
Okay, great. I think will be the last question. So in your experience, what is the most difficult case for like leg ulcers? Also, we'll just like go for 30 seconds because we have to wrap up.
That's an easy answer.
Yep.
It is a leg ulcer with calcinosis cutis secondary to scleroderma.
Great.
There, that was 15 seconds.
Great. That's nice. Okay, to you, Kath, to wrap up.
Thank you.
Thank you.
I think, Lee, if you had another 20 minutes, you could explain the details of that.
Maybe.
Thank you both. Thank you all for your presentations, and thank you, Mohamed, for moderating. And thank you to our audience for attending the Chronicles of Wound Scene Investigation series, brought to you by the Wound Healing Society's Education Committee and Wound Healing U. And just as a reminder, the recording recording of this webinar will be available on your membership only account on the Wound Healing U in the next few weeks. And please plan on joining us for the next webinar. Your registration entitles you to attend all the webinars in the series, and the next one will be at the same time, 6 p.m. Eastern on March the 7th. The topic then will be inflammatory ulcers, swollen legs, itch, and gout. So a whole bunch of stuff. Thank you, everybody, and good night.
Thanks, Kath. Thanks to everybody.